Hi, and welcome to Healthy Living. I'm Debbie Lyons here today with Kelly Presnell, Director of Public Relations and Marketing here at Hilton Head Hospital. And we have an interesting show today. We're talking to Dr. Aaron Mason.
Yes, Dr. Aaron Mason is one of our plastic reconstructive surgeons who's on our medical staff. He is part of our Comprehensive Breast Health Center team as well. He works closely with Dr. Herman and the Breast Health Center, in particular women that are considering reconstructive surgery. So
and I think that's what he's going to be talking about today.
He is reconstructive surgery. Many women don't necessarily talk about it or know what their options are, so I think it's important for us to have our physicians on to talk about these things openly for women so that they know what their options are.
Exactly. Dr. Aaron Mason will be on in just a minute.
Dr. Joyner. Dr. Joyner to ER.
When you're sick and need to go to the ER, it's no fun to wait. There is a smarter way. Check in online at HiltonHeadRegional.com and skip the ER waiting room. Hilton Head Hospital, the smarter way to ER.
Pain. It can be different things for different people. A shoulder that takes you out of the game. A knee that stops you in your tracks. Ready to return to a better you? Hilton Head Hospital is here, right in the Low Country, to help heal what hurts. From diagnosis to treatment to full recovery, our fellowship-trained orthopedic specialists are committed to getting you back to your best. Hilton Head Hospital. Extraordinary care right here at home.
Hi, and welcome to Healthy Living. Kelly and I were just talking. We're going to talk today to Dr. Aaron Mason, and we're talking about plastic surgery. I'm very excited about that. Today we're going to talk about something that I think many of us are very curious about, a little intimidated by, slightly frightened of, if I may be so blunt as to say, and that is breast reconstruction after surgeries. Can you talk with me a little bit about, I mean, what does that term mean even to many of us as women today?
Well, breast cancer for women is a very real possibility.
Correct.
And in the United States, we know that 1 in 7 to 8 women will have breast cancer in their lifetime. And with that, the identification and treatment of that has become much more streamlined.
Okay.
We've evolved with the breast oncologic surgeons, much more refined and kind of more specific techniques. But even with that, a number of women come to mastectomy, which is the removal of the breast gland in treatment of breast cancer.
And what's interesting to me, just kind of speaking off the cuff, is I think from a media point of view, it's so much more front and center now. You know, I hear of women who have DCIS or think, you know, early detection who are still opting for mastectomies as opposed to other treatment options.
I do think the media has contributed to folks or to ladies kind of moving toward mastectomy, perhaps particularly in the other breast who's unaffected, a little more than we've seen in the past. Certainly Angelina Jolie's recent mastectomies and reconstruction have brought that to the fore.
I know, good thing, bad thing. We don't,
yeah, and I'm not sure the oncologic surgeons would say that that's something that we should be pushing per se, but it's certainly something that they entertain and discuss with patients depending upon the individual as to whether that's appropriate for them in their specific case.
And especially for us talking about breast reconstruction. I mean, that's exactly what we're talking about.
Right. So those would be the individuals that when they come to mastectomy, if they elected to, would be candidates for reconstruction. And by reconstruction, what we're doing is we're adding that breast volume back to restore what aesthetically looks like a normal breast. And that can take various forms, and that's where I interface with the breast center here and the work that Dr. Herman does at the breast center. She directs the program.
Yeah, she's amazing.
Out at the site in the Bluffton Medical Center in Bluffton. And so my interface becomes when she sends folks over who are candidates for mastectomy. And for those individuals, we talk about what can be done to restore breast volume.
Okay, so I walk in as a patient, and the first thing that we're talking about is I know that I have breast cancer.
Right.
And am I at that point reviewing my options?
Well, at that point, a lot of ladies are ready to talk because they just want to get it behind them,
Right.
move forward, get the reconstructive process started, and be done with it. Some ladies are very different. It's a big hit, particularly since I don't know anyone who's planned for breast cancer to be told that you have breast cancer. So it can be a lot of data, and we kind of weigh that on the individual as to how much they're ready to kind of digest that day. But the goal for the first visit is to just talk about options,
Okay.
to kind of ferret out if they're not candidates for specific procedures based on prior radiation, if they have diabetes, if they have other medical issues that would preclude certain avenues being successful or
Makes
having more
sense.
complications.
Okay.
And then what I usually try to do is give them a booklet to take home. I tell them not to read it the night of, but when they have time and they can kind of put
Process.
things in a place where it's easy to take information in, and then review that. And then we have a second visit afterwards if they
choose.
choose to do reconstruction, where we go into more depth and we do things like measurements and exams and sizing and those kinds of things.
And that was one of the things I wanted to ask you. What is the second visit? You actually sit down and
Right, so at the second visit, we decide exactly which course we want to pursue. And based on what that is, we walk down that path. And there's really two avenues that you can take in breast reconstruction. One is to use your own tissues.
okay. And what does that mean?
And that involves using either skin and fat from the abdomen or the back. Those are the two most common sites. And transferring that tissue to the chest wall to restore volume to the breast.
Pros and cons of that.
Well, everything has pros and cons.
Okay,
right?
fine. Right. Oh, yeah. 100%.
So
Yeah, we're going to go
there's
through each
no-
one of the
there's
pros
not-
and
right,
cons.
So there's
yes.
nothing's without its cons,
Right,
unfortunately.
correct. Benefit risk.
But in those patients, for instance, who have radiation,
Okay.
they're going to be a poor candidate to use
Okay.
an implant in the end because the effects of the radiation on the skin and the soft tissues, particularly the microvasculature that supplies them, are profound. And we know from years of doing this that in those individuals who are radiated and do implant-based reconstructions, their complication rates are much higher,
Okay.
significantly higher. So much so that in general, the majority of reconstructive surgeons will not recommend that as a first option.
Okay.
And so with that, those ladies are candidates for using their own tissue, providing they have enough tissue to give them the volume that they want to restore their breast size. And so in those folks, we would elect to either use their back or their abdomen as the donor site. The pros is it's your own tissue.
I was going to say, yeah, I would
right?
think that makes
So you don't
yes.
identify as foreign. There's no capsule evolved around the tissue that's transferred, and it in general takes the form that you want. You do well. The
Okay.
downside is that you have a donor site defect.
Right, you have, exactly, that makes sense.
If you need both sides reconstructed because of the way that the abdominal wall is dissected to get the tissue,
Okay.
you have a potential for hernias.
Okay.
You can have seromas, which are fluid collections under the abdominal wall after it's reconstructed.
Typically, when there's a donor site, is that just a little bit more of a recovery time?
Well, there is more recovery time, and often, in the majority of cases with tissue transfer, there's going to be more hospital time.
Okay.
And then
It's so interesting.
And then depending upon what technique you use, the length of the operation is longer,
Okay.
usually. The recovery period is usually longer.
Okay.
Your complications are pretty much a spectrum of in everything, but they are a little higher. For instance, if you do a free tissue transfer where you're completely separating that tissue from its blood supply and then reestablishing that at another site via microvascular techniques, potentially that new connection could clot and you would lose the whole flap or part of the flap.
So there are just a lot of variables
there are a
out
lot of
there.
little things that can happen, and we talk about all those as
Okay.
prospects. And some of those techniques we do here in the area, and some of them are more advanced, particularly the microvascular work. And for that, we send ladies up to Charleston, to the
Okay.
breast center, to the breast reconstructive surgeons there for those, because they do those types of complex reconstructions on a regular basis, and they have ancillary staff that's used to caring for them.
Are there nipple-sparing techniques, or is that part of the...
Yes, so that's a completely different discussion.
Okay,
But, so
all right,
how you
well,
take the
we
breast
can-
off.
we can
puts-
put
yeah,
that over here.
But that is
Okay.
true.
Uh-huh.
Well, let's come back to
Okay,
that because
okay.
we started down the
Okay,
reconstructive
good.
avenue. And so the one avenue is to use your own tissue.
Good.
The second avenue is to use an
I
implant.
like you. Uh-huh,
Okay. And this is how I talk to people, because
Yeah.
you can diverge and then you lose track
No,
of what
that's
you're diverging
exactly-
of, right?
yes, I love
so
this.
you like to stay
Uh-huh.
on a. I like to make things very simple.
Good.
I'm from West Virginia. We're very simple people.
I hear you.
So So if I keep it
I'm in
simple,
Ohio
then I
and
get it, and then hopefully everyone else can get it too. But so the second option is that being using an implant.
Okay.
So if we use an implant, ideally, and we recommend not for a radiated patient, obviously.
Correct.
Generally, we want ladies who would like to be a C cup, B cup.
Okay.
Very large-breasted ladies, or ladies who want to be very large-breasted, are not going to be a great candidate for an implant. And otherwise relatively healthy. So those
Okay.
folks, now the problem or the challenge becomes is that oftentimes at the time of your mastectomy,
Okay.
we, being your treatment team,
Correct.
may not know that you're going to need radiation yet. So it is possible that you could enter the day of your mastectomy, and our recommendation being that you're not going to need radiation, but have a lymph node that comes back positive.
So now
and
we
in
have to
general, if that's the
shift.
case, then we have to change streams. But,
Okay.
but for the most part, in those ladies who are a candidate otherwise for an implant, we walk down that path. And so you ask about the second visit. So at the second
Yes.
visit, we decide what path we're going to go down. The majority of ladies that I care for here, because of the need for more specialized treatment, are going to be implant-based reconstructions.
Okay.
And so with that, we talk then about what implant type do you want to use. Do you
Okay.
want saline or silicone gels?
Pros and cons of those. I'm trying to stay on task.
Yeah, for
Okay.
reconstruction, excuse me, pros and cons of the silicone are that in general there's less rippling than if you use saline. You can use either one.
What does a ripple mean?
Rippling is the actual device
Okay.
has gentle waves on
Okay,
the
got
side of
it, got it.
If you came to me and you just wanted to be a C cup and you were an A cup for augmentation, your native breast tissue would drape over that. So the chances of seeing that rippling is much less.
Got it. But now
In the
you're
instance of reconstruction, because
Yes.
we've removed the breast
Correct.
gland, we don't have that luxury
I
of
got
something
it.
to drape over. So things that are underneath the skin literally are reflected in a very obvious way oftentimes
Got it.
on the outside from what we see. And the areas that are most affected are going to be on the side of the breast or sometimes in the medial part of the breast, particularly if you lean over.
Okay.
And so in an effort to reduce that, the silicones are often better
All right.
because they, even though you can still see some rippling, it's often less than you will see with the saline. Although, and there are instances you saline. For instance, some ladies are very uncomfortable having silicone because of all the concern with silicone implants
Okay,
in
got
the
it.
80s.
Right.
And even though those have been studied and those have been shown to be not related to cancer or to collagen vascular disease, and the silicone are safe and they've been re-released by the FDA, and we use them very often. As a matter of fact, we probably use them as often, if not more so, than saline these days. But there are some folks that are just very uncomfortable with that.
Okay.
So if you can't sleep at night knowing that you have a silicone implant, you should
Don't
not
get
use
one.
a silicone implant.
Okay.
You should use a saline implant. And so we have that discussion, and then we decide which one we're going to go. And then we talk about the operation, and we talk about the recovery, and we talk about the drains, which no one likes because
Right.
they're a thorn in the side, but they're a necessary evil. You know, answer any last minute questions and then make preparation for the day of.
That makes so much sense. We're going to take a quick break.
Sure.
But you're not off the hook yet because we've got a lot more questions. So
Okay.
stay with us. We'll be right back here
Thank
on
you.
Healthy Living.
Pain. It can be different things for different people. A shoulder that takes you out of the game. A knee that stops you in your tracks. Ready to return to a better you? Hilton Head Hospital is here, right in the Low Country, to help heal what hurts. From diagnosis to treatment to full recovery, our fellowship-trained orthopedic specialists are committed to getting you back to your best. Hilton Head Hospital. Extraordinary care right here at home.
Hilton Head Regional Medical Center is located at 25 Hospital Center Boulevard. When traveling east on William Hilton Parkway, make a left-hand turn on Beach City Road, and the next left, Hospital Center Boulevard will be located just past the Hilton Head Library.
Coastal Carolina Hospital is located on US 278 at Exit 8 on I-95. Telephone is 843-784-8000. On the web, www.coastalhospital.com.
The vision for Hilton Head Spine Center is very clear. It's to provide world-class spine care to our patients. Physical therapists were there. They were there holding you up. It's nice.
I just love working with all of these patients and their families and getting to know them and helping them on their journey.
My life is definitely better, and I'm glad that I came here at Hilton Head Hospital.
We are back here on Healthy Living. We're talking today to Dr. Erin Mason, and we're talking about breast reconstruction. In the first part of the show, we talked a little bit about options that are available when reconstruction is necessary. Now we're going to talk a bit more about techniques.
Yeah, well, you touched on earlier these nipple sparing, which people are aware of. I mean, I get the question in the office, and really it's people wouldn't know, but that's a question more for the breast oncologic surgeon, so Dr. Herman, because
we know that.
Because what it is a technique wherein the nipple areolar complex is left behind rather than taking it with a specimen when the mastectomy is done. But it does bear on me, in as much as if it's taken, then we make plans to reconstruct it at the end of the reconstruction. If it's spared, then I need to take that into consideration, because if the breast is particularly large and or has dropped on the chest wall, then the nipple position has followed. And so if you just leave a bunch of skin in between, it becomes almost impossible to extremely difficult to move it up after you've taken the breast gland, which is the blood supply to the nipple.
Which makes sense.
The planning for that mastectomy becomes more interesting.
Well, I can imagine.
If you're nipple sparing. Now, I'm sorry, not to interrupt, but so just to kind of, before we jump off of the techniques for a mastectomy, you know, in the old days, the mastectomy included removal of not only the breast gland skin, but also the muscle. And so those techniques now have really evolved to the point where in almost all instances, the skin is spared, and we call those skin sparing.
Okay,
and that's what has been done probably in the most volume in the last 15 to 20 years. And then recently, within the last 7 or so years, the advent of nipple sparing has become more and more evidenced.
And why skin sparing or nipple sparing? What would be the determination of that?
Well, tumor location probably is the largest. So if the tumor is significantly enough close to the nipple areolar complex, the recommendation is going to be to take the nipple areolar complex with the mastectomy.
Tissue is the issue.
Correct. If it's far enough away that Dr. Herman feels like it's safe to leave the nipple, then that will be an option. But in almost all instances, the procedure is done skin spared. So I always have some skin to work with. I can't remember the last time that wasn't the case.
Is the goal for you with your patients aesthetics? Is it practicality? I've often wondered, I think I told you my sister had a double mastectomy and breast cancer, and it was very interesting because I sat with her during the entire procedure. My thinking and my point of view and my questions were very different than hers during different phases of the whole process. It was fascinating.
I see that. I mean, initially, I think ladies just are surprised that there's an option.
Right.
Then there's the just wanting to survive cancer phase. Where you don't really care what size you are, you just like to have the cancer out. And interestingly enough, but badly placed, is the I've got implants, but I'd like to be bigger phase.
Exactly.
And so I always try to encourage them as we go through to take the lemon and make lemonade.
Yes.
Right? So think about where you want to be. And that's hard sometimes because I think it is, I mean, it's easy for me to say, but I don't have breast cancer. I'm not a cancer survivor. And so, you know, where that individual is in that continuum is often very different, and certainly is different for each individual. So we try to take that into consideration, but what I do try to stress is that nothing's final. So we can always revise or change or modify. And I think the one thing that
nothing's concrete barriers. We've got orange cones we can move around.
And the thing that's hard, I think, is that it is more of a process to do an implant-based reconstruction, because you've got your initial mastectomy with usually placement of an expander. And then an interval of months where you're expanded, and then ultimately the expander's out and the implant's in.
Am I allowed to ask about what an expander is yet?
We'll pop back to that. And then if we do a nipple areolar complex reconstruction, we have yet another procedure, and people just want to be done with that. But there's a lot of change in that time period, because it can be up to 7 to 9 months. And so if you lose weight and you've only had one side done, then the other side is going to change because you're going to lose fat. So what I try to stress is that nothing's final. We can always address concerns, and putting a finite number of number of operations that need to be done is going to be different for everybody depending on where and how they want to look at the end.
Here's what I heard you say. My takeaway as a woman is be patient. We're part of a team, okay? And together we will go through this process.
Right, and I have to be careful too because oftentimes I'll see someone back and I'll look and to me things are a little asymmetric or cattywampus and I'd like to make some revisions and she's
They're
more
so
than ecstatic.
happy.
She's ecstatic, so I have to keep my big trap shut and
I
wait
hear
till she
ya.
tells me how happy she is. And that's one of my first questions at the end is, are you happy? And I think they look at me like, are you kidding? I just had breast cancer.
Exactly.
But it's an important question because if you're not happy, then we're not done.
Okay.
If you're happy and I'm unhappy, then I need to keep my mouth shut.
Right. Well, no, that's true.
Right.
That's
and if we're both unhappy, then we need to
talk about it. Right, exactly.
Exactly.
Can I ask about expanders yet?
Yes, so now back to expanders.
Okay.
So expanders are these
You're like
devices
the most
that look
fun
like
person
little
ever
Why,
to talk
thank
to.
you. Yeah. Tell my office staff.
Oh.
Okay.
Oh, oops.
No, I'm just teasing. So expanders are these devices that are probably most analogous to a balloon.
Okay.
So they're placed in empty. They're the shell of a implant, but they're empty.
Got it.
They have a little port on them that allows us to access them by placing a needle through the skin into that port and then putting volume, and we usually add saline.
Okay.
So they go in empty, we close your incision, and then over a series of weeks afterwards, we gradually add volume until we stretch the envelope of skin to the volume you want to be.
Brilliant.
So if you want to be a C cup, we place them, we do the expansions, once to the size of a C cup, then we go back after the tissues relax for about 6 to 8 weeks and put in the implant.
Gosh, I think so many of us have heard expanders and, you know.
Well, yes. So not everyone has had a positive experience with expanders. If you get online and you look at those who have gone through this cascade, there's a lot of negative experiences with expanders. And I think that comes for several reasons. I think that some surgeons are too aggressive with expansion. They have in their mindset that they're going to have you expanded in 1 month and they put 100 cc's where you can tolerate it not and tell you to go home and take ibuprofen. And that's a strategy. It's probably not going to be one that the patient remembers as particularly positive. So the way I expand is we do a lot of local things to numb up the area before we put the needle through. And they drive the bus when it comes to the volume. So I've had some ladies who can tolerate 60 or 70 cc's at an expansion or 100, and I've had some that tolerate 15 or 25. And as I tell them, there's no gold star for finishing early. You just need to get the end at the end of the day. And if they're going to be uncomfortable for the next 7 days between the next expansion, there's no reason to do that.
There's no point.
So I try to make it as memorable only for positive reasons as positive. Having said that, there's no doubt that there's a sense of distension as you add volume, particularly as you end expansion. So the further out you get, you're stretching things more and more. Much like the 9th month of pregnancy, you feel much more distended than you do the first week.
True.
And again, try to make that as pleasant as advanced as it can be, given we are stretching tissue to use later for the reconstruction. I think having done that, and I don't know, I've not had anyone, I've had a couple patients who have been uncomfortable, but the most of them are fairly comfortable during that process.
All right, so now I've gone through the process. I've gotten my 2 options, correct? My 2 options. I've gone through the actual procedure, and I've come out on the other side. Now what?
You're sick of me.
Oh, I'm over it, right?
Yeah, you're over it. So once we've made a breast mound, so you've had your implant placed and your expanders out and your implants placed, then the decision becomes, do you want a nipple? Well, if you've not had a nipple sparing, do you want a nipple or not? And that is another small procedure that we do to make a nipple. And then once that's healed, to make the areola, which is the pigmented tissue around the nipple, there's a tattoo method for medically tattooing that so that we can get the areola.
Gosh, it's really quite intricate, isn't it?
And then the other thing is if you've only had one side done, then we'll often need to do a matching procedure because, say for instance, you were a C cup at in construction, but even if you have the volume on the left side and it's droopy, then you're going to want to lift. And it's important to note that those things these days are mandated by the insurance carriers to be paid for. So, you know, it had been where the insurance company would pay to reconstruct the breast, but not pay to do a symmetry procedure to the opposite breast. That is no longer legal.
Good.
So those two things are covered by, it's mandated that your carriers cover it.
Once I've had the procedure, I've healed, then do I return to you every 3 months, every 6 months?
So once we're done, you're happy and
Right.
you're out doing your thing. I like to see at least once a year.
Okay.
Because with the implants, you still have the same risk as anyone else of having what's called a capsule that becomes firm and tough, evolve around the implant. And what a capsule is your body's way of identifying that there's a foreign body there. And so it lays down scar tissue. And in many ladies, that scar tissue becomes and remains very supple and soft. But in a small number of ladies, it becomes firm and tough and either displaces the implant in a position that it shouldn't be seated, causes discomfort to the patient, or both. And in those settings, we have to go back and do something else.
I have to tell you that talking to you is really, it is very profound in this manner for me, and I think a lot of women. I think it's a scary enough thing to go through, and to have a physician that's willing to sit there and chat with you and just make you feel more comfortable with what's going on. Like we really are kind of working part and parcel together. Makes a lot of sense. I
Right.
appreciate your time today.
Oh, you're welcome.
I mean,
My
it's
pleasure.
very interesting. We'll have to come back and
Yes.
talk about other ancillary things that I still have sitting here on the table
Sounds like a
ready to
plan.
talk about.
Let's do
Thank
it.
you all for joining us here on
Thank you.
Healthy Living. Have a great week.